get started, so please take your seats. We want to have enough time for you to have questions and dialogue with our panelists. I'm Cheryl Bartlett, the Commissioner of the Department of Public Health, and I'm delighted to be moderating this panel with Dr. Ann Huang, who's the Director of Health Policy and Strategy at the Executive Office of Health and Human Services, Dr. Paul Haddis, who serves on our Health Policy Commission, and also works at Tufts University Medical School, and Dr. Tom Land, who works at the Department of Public Health. I'll tell you a little bit more about each of them before they speak. Each panelist will be speaking for approximately 15 minutes, and then we will open this up for a dialogue. And I'm assuming there's a mic out there for you folks to ask questions. I think our theme today really is important about and how it relates to healthcare reform, and I think we have three people with us that really can help you get a perspective on where we are both nationally and in Massachusetts. I am thrilled at the Department of Health that we have a role in healthcare reform, particularly as I spoke earlier today about the Prevention and Wellness Trust Fund and the work that we are hoping to do by linking the community to clinical care and see health improvement and cost savings and try to take people out of more expensive hospital and medical care. So I'm excited. As we all probably know, on October 1st, the Affordable Care Act went into effect, and we have probably mostly heard about the problems that have happened on a national level, but I think we're fortunate here in Massachusetts that we've had healthcare reform since 2006, and we've been moving in this direction, and so we didn't have those same experiences that people are having in other states. But first we're starting out with Dr. Ann Huang, who is, again, the Director of Healthcare Policy and Strategy for the Secretary of Health and Human Services. I've had the pleasure of working with her on a number of initiatives. She plays a leading role in the implementation of all our major healthcare initiatives in Massachusetts, including the Affordable Care Act, healthcare reform, and cost containment initiatives that, and the Commonwealth State Innovation Model Grant. I've worked with her on the implementation of the Wellness Tax Credit, working on the Prevention and Wellness Trust Fund, and the Health Planning Council. So I am thrilled to turn this over to Dr. Huang. She's had a series of other health policy positions, both nationally and in Massachusetts, and she is also an actively practicing physician and board-certified internist. Thank you, Dr. Huang.
Thank you, Cheryl. Actually, I think I might speak from the podium so I can advance my slides. I'm honored to be here with both Dr. Haddis and Dr. Land to talk about health reform and public health. I was told I have a strict time limit of 15 minutes, so this will be sort of the highlights tour through some of the major initiatives, and would be happy to go through things in more detail and through questions. What I wanted to do was first just to provide some context for health reform, then some highlights of the Affordable Care Act, and then highlights of Chapter 224, which is our state's health care reform law, which was signed by the governor last summer. So in terms of context for healthcare reform, I pulled this one from the oldie but goodie file. This is a paper that actually came out in 1961, and I wanted to start with this slide because I wanted to start from the perspective of if we were designing a healthcare system, how would we want to design it? So forget that we actually have a healthcare system, and think about what are the needs of the population as a whole. So what these researchers did is they looked at if you take 1,000 people, what kind of healthcare do they actually need in a given month? What services do they access, and how frequently do they access those services? And what you'll see is that out of a population of 1,000 adults, about 750 will report some kind of symptoms. So that might be those of you who have colds or low back pain from sitting in these chairs. So this is very common. But of these 750 people, 250 of them will see a physician, 9 are hospitalized, and you'll see in that tiny, tiny, tiny lower right box that about 1 person is hospitalized at an academic medical center. So if you think about how our healthcare system is designed, it's really skewed towards that lower right tiny box in the corner, but we sometimes forget that most people are actually what I like to call free range. They're actually out and about doing their thing, and their access with the healthcare system is not in an academic medical center. And you might say, look, this was 1961, lots of things have changed, the healthcare system must be very different. And actually this study was redone in 2001, And while you'll see that there's actually there's some new boxes on here, such as visits to alternative medicine practitioners and other boxes, the numbers are surprisingly similar. So out of 1,000 people in a given month, 800 report symptoms, 217 visit a physician's office, 8 are hospitalized, and less than 1 is hospitalized in an academic medical center. So again, thinking about sort of what are the needs of a population versus how is our healthcare system set up, I think these slides provide some interesting food for thought. The other thing I just wanted to point out is moving on, thinking about why does this matter? And this matters because our healthcare system is not optimally designed. That's probably not a surprise to those of you who have been patients or who have worked in the healthcare system, but I think it's important to acknowledge. So if you look at healthcare costs, I do want to caveat this is quite an old slide. This is a 2009 slide by the Division of Healthcare Finance and Policy, which does not exist anymore. But I think it makes an important point, which looks at the rate of healthcare cost growth, which is the top line, and it compares to per capita GDP, average wage and salary, and the consumer price index in the Metro Boston area. And basically, while there has been some moderation in the past few years in healthcare expenditures, healthcare expenditure growth still far outpaces economic growth, and this creates problems because it means that it puts increasing strains not just on state and federal government budgets, but also on our budgets of individual households. The other part of the story is that much of the growth in healthcare costs is unnecessary. So these numbers are based on research that the Institute of Medicine did. It was cited in the 2012 report, Best Care at Lower Cost, but was looked at in more detail in their 2010 report, and categorized basically total healthcare spending, which is $2.5 trillion per year, which if you assume a population of about 250 million, that's about $10,000 very roughly. Of that, about 30% is unnecessary, and this is categorized as unnecessary services, excess administration, inefficiency, high prices, fraud, and missed prevention. And you'll note, since this is a prevention audience, I should just mention that missed prevention opportunities were estimated looking at a set of prevention services provided in a clinical setting, things like tobacco cessation, obesity counseling, aspirin in high-risk populations. Even the smallest number there, 55 billion, far dwarfs our state's entire budget for the entire year. So even the small box there is quite a big number. So in this context, controlling healthcare costs is a very important priority for the Commonwealth. And in terms of how to do it, this slide lays out sort of the key goal of improved affordability, accessibility, and quality of healthcare, which is tied very much to the triple aim, which I was told to mention as many times as possible this morning. But that term basically refers to improving the health of a population, enhancing patient experience of care in terms of quality, access, and also reducing or controlling the growth in per capita healthcare costs. So that is your CEU plug for the day. In terms of how we're going to do it, there are 3 components, including payment reform, system redesign, and consumer engagement. And these strategies are in turn characterized by a number of different levers, many of which are encapsulated in the state's healthcare cost containment laws. So this includes payment reform, increasing transparency, preventing illness, promoting good health, malpractice reform, health planning, innovation in health insurance design, and health information technology. And many of these threads are things that many of us at this table have been working on to push forward in the context of implementing Chapter 224. I do want to just talk a little bit about what we mean by payment reform, and I understand that Dr. London will be covering this in quite a bit more depth, but I just wanted to give a quick highlight about the rationale for changing the way that we pay for healthcare. So on the left, you'll see this picture representation of how we currently pay for healthcare, which is fee-for-service. So if I see a patient for a 40-minute visit, I'll bill for that visit, I'll get paid for that visit. There's nothing wrong with that, but there's no inherent incentive in that system for paying for the quality of care that's provided, and also for coordination of care, or for reducing care, for that matter. So you tend to have incentives that promote sort of siloed care, where each physician or each service line provides its service, and there isn't an incentive to speak to one another. So global payments try to address that by providing more integrated payments that allow more flexibility in how the care is delivered. And I do want to just, again, preview, I think, some concepts that will be discussed in more depth in other sessions by putting on here just some rough, a little alphabet soup of some of the terms that are used to describe different types of payment reform. What I'm trying to show in the spectrum is very roughly, again, this is high level, but very roughly, payment arrangements that have more risk sharing on the right, and starting with the left with the traditional system, which is fee for service. So in some ways, there's no risk for a provider in the sense that you provide a service, you get paid for the service. The next box refers to fee for service plus P for P, or pay for performance. So that's an arrangement where a provider would provide a set of services, and then they would have a certain amount of payment that is either a bonus payment or that is withheld based on whether they hit certain quality targets. I should also mention these are not mutually exclusive. The third box refers to shared savings or shared risk arrangement. Generally speaking, again, this is where providers are managing patients, the total cost of care for a patient toward a certain budget, predetermined budget. If your patient's total cost of care, or your panel of patients' total cost of care is below that budget, you might share some of those savings. If you're over that budget, you would have to pay back or not get paid a certain amount of that, and that's referred to as shared risk. Bundled payments or episodes of care is instead of paying, for example, for someone's going to have knee surgery, paying a fee to the surgeon for that knee surgery, a fee for a pre-operative visit, a fee for a post-operative visit, a fee for physical therapy, a fee for medications. A group of providers would be paid a fixed amount for that whole episode of care. So you get one bundled payment that's supposed to cover all your pre-operative evaluation, the operative treatment and stay, and then any post-operative care. Again, the idea there is for the providers, to incentivize the providers to provide that care efficiently. Partial capitation refers to a per member per month payment for a set of services, and global capitation would be a fixed per member per month payment for any service that a patient might need. And again, this refers to the ways that payers are paying providers. And a payer could be a health plan, it could be a government payer, or it could be, in some cases, an employer. So with that, I'm just going to move on and talk a little bit about the Affordable Care Act. And as the Commissioner mentioned, it has been an important priority in Massachusetts. It certainly brings, while we've had healthcare reform for a number of years, there are benefits to the Commonwealth from the Affordable Care Act. Some of the key features of the Affordable Care Act include expansion of Medicaid coverage, creating additional affordable insurance coverage options for families with incomes up to 400% of federal poverty level, which is about $46,000 for an individual and about $94,000 for a family of four. It has federal tax credits to make insurance more affordable. It creates health insurance marketplaces, which are the things you've probably heard about. I was actually listening to Tom Ashbrook in the car on the way over, and they have a whole morning about that. It has insurance market reforms and consumer protections, and it has a requirement for adults to get health insurance. So that's something we've had in Massachusetts for some time. While many of the people have talked about the Affordable Care Act is very important to coverage expansion, which it is, and many of those examples I gave you were all about expanding coverage, it's also important to remember that the Affordable Care Act includes a lot of components to promote health system reform, including improved quality and efficiency, stronger workforce and infrastructure, and a greater focus on public health and prevention. So I wanted to focus a little bit on these items because we don't necessarily talk about them quite as much. So in terms of some of the public health provisions, since 2010, health plans have been required to cover certain preventive services that have an A or B rating from the U.S. Preventive Services Task Force without a copay and pre-deductible, and Medicare has also is now providing a number of preventive services in the same fashion. There's funding for community health centers, and in Massachusetts, community health centers here have received more than $130 million. The Prevention of Public Health Fund, which funds initiatives that improve health and restrain healthcare cost growth, including targeting obesity, tobacco, and also increasing access to preventive care. And I just want to mention that that is distinct from the Prevention and Wellness Trust Fund, which was part of Chapter 224, which Dr. Land will speak about more in depth. As a result of the ACA, Massachusetts has gotten grant funding for 23 different public health projects. In terms of payment reform, The Affordable Care Act certainly supports many initiatives towards payment reform, including Pioneer Accountable Care Organizations and Medicare Shared Savings Programs. So these are programs where provider organizations are engaged in shared savings or shared risk programs that I showed on the previous graph. It strengthens primary care by providing enhanced payment rates to primary care physicians in Medicaid as well as in Medicare. It provides an opportunity for states to integrate care for individuals who are solely called dual eligible, so eligible for both Medicare and Medicaid, and Massachusetts is participating in that through what we are calling the One Care program. And it provides funding to states to test innovative payment delivery system reforms through the State Innovation Model Grant. And we are one of the 6 states that have a model testing grant through CMS. So now that we've summarized all of the Affordable Care Act, we'll move on and talk about Chapter 224. It's only 2,000 pages, so it's a quick read. So Chapter 224 also has, as I mentioned with that earlier wheel diagram, there are a number of different strategies, and they align quite well with what's in Chapter 224. I know Dr. Hattis is very deeply engaged in all these issues as a commissioner for the Health Policy Commission. One of the key features of Chapter 224 is setting a benchmark. So the state has a clear goal, which is to restrain the growth of healthcare costs so that they are not growing faster than the state's economy. Promoting payment delivery system reform within both the public and private sectors, promoting prevention and wellness, and we'll talk a little bit more about that. Investing in health information technology, increasing scrutiny of healthcare market power and price variations, such as through the cost and market impact reviews that the Health Policy Commission undertakes. Supporting the expansion of the primary care workforce through loan repayment programs, and also through a healthcare workforce transformation fund administered by Labor and Workforce Development. Providing information to consumers and employers, enhanced information to consumers and employers about the cost and quality of care, and also looking for opportunities to streamline administration of healthcare. So some of the public health provisions include the Prevention and Wellness Trust Fund, which is provides up to $57 million over 4 years. Wellness tax credits, which allow small businesses to receive a credit for part of the cost of administering a workplace wellness program. The creation of a model wellness guide, which the department has completed. It also includes wellness as one of the considerations in the context of certifications of ACOs. So the Health Policy Commission is tasked with developing the criteria for organizations to become certified as accountable care organizations. And in doing so, they can take into account a large list of considerations, but one of them is to promote community-based wellness programs and community health workers, and that is something that was included in Chapter 224. So in summary, I think I'm doing okay on time. Wanted to just maybe state the obvious and say this is a very dynamic time in healthcare. We certainly have seen lots of changes over the past several years and expect that there will continue to be tremendous change. I think there is a great opportunity in this change to really think about how we want the healthcare system to look moving forward, and that prevention is an important strategy in the context of health reform. And there are lots of opportunities within the context of both state and national reform to ensure that prevention continues to play a key role. So with that, I'll wrap up. That would be happy to take questions at the end.
Thank you, Dr. I think you gave us a lot to think about related to our title of this plenary session, Steering the System Upstream, and certainly 96% of our resources are spent on sick care and about 4% on health promotion. And these models of payment reform really should help us to change that equation and hopefully invest more in health promotion. Our next speaker is Dr. Paul Hattis, and Paul Hattis serves as a Senior Associate Director of the Masters in Public Health program at Tufts University Medical School. And he also has been at Tufts since 2002 as a faculty member in the Department of Public Health and Community Medicine. Dr. Harris was appointed in November of 2012 by Attorney General Martha Coakley to serve on the Massachusetts Health Policy Commission, where he chairs the Community Healthcare Investment and Consumer Involvement Committee, and he also is a member on the Cost Trends and Market Performance Committee. Dr. Harris is board certified in public health and preventive medicine. He's also an attorney who has served in the office of the General Counsel for the American Hospital Association, and he will speak to us today about some particular challenges and opportunities related to integrated care, payment reform, and key provisions of the Affordable Care Act in Chapter 224. Thank you, Doctor.
Enjoyed what Ann had to say and look forward to Tom, but I think really I want to say that I look forward to the discussion questions and interaction with this group. Cheryl was kind to sort of say, my identity is primarily as a public health professor at Tufts and now in the Health Policy Commission, but I sort of want to talk to you guys in the little time that I have. I'm going to ask Jeff to help me that at the 12-minute mark, why don't you give me this kind of a sign so I know I've got just a couple minutes left. I really want to talk to you wearing a hat that I worn earlier in my career, which was sort of like a provider person, right? I've been a vice president of medical affairs of a hospital, public health physician, and I think integrally to the notion, and I don't know whether some of you come from governmental public health and some from the provider, insurance, community or related foundations, and some of you come from maybe community advocacy organizations or focus on special issues, like cardiovascular health and wellness, obesity or smoking, etc. But the challenge to all of us is how do we get aligned to ultimately get the right system so that whether it's the 4%, hoping it grows from the public health side, or the 96% that's been the personal health care side, that we sort of reallocate those resources to both get the optimal health status, the most affordable system in a quality way, and improve everybody's health. So that the triple aim, the IHI triple aim is about population health. That's sort of the newest piece for providers to think about. It's about reducing the growth of costs or efficiency. And they used to stand very strongly for quality, and I think they broadened that to talk about patient experience, which is quality in all sorts of ways. So I want to give a shout out to the AAA. The thing I want to say to you, the punchline about all this, and it's true I think whether you're thinking about the ACA or our own Massachusetts reform, is I think to think about the progression this way. If Romneycare, or our 2006 law, equivalent to the federal 2010 Obamacare law, or the ACA, is sort of healthcare reform 1.0. Its primary goal, although they do different things, its primary goal for both of those was reducing the number of people without an insurance card in their pocket. Okay? So it's financial access in particular. In Massachusetts now, we've progressed to healthcare reform 2.0, which is trying to deal with the cost and quality aspects of personal health services primarily. It isn't to take away from the important things, and I was before a group of you folks on the chronic disease side, and I really do wish this, about how we can look at Chapter 224, and Ann just made some reference. There are important things in there, that public health and wellness trust, and there's opportunities both with the ACO regs, accountable care organization regs that we have to generate on the commission, or even the patient-centered medical home regs potentially. But fundamentally, that law is about reducing the growth in personal health care services spending and trying to maintain or improve quality. It's really only going to be healthcare reform 3.0 that hopefully maybe we'll get to sooner as opposed to later, and people talk about getting to really the population notion of public health. Okay? And I know many of us want to get there sooner as opposed to later. And that isn't to say that we haven't in some ways thought about that, historically. I'll just take one little tidbit, but for example, many of us talk about the community health centers. Jack Geiger, who was from my department at Tufts way back when, was considered the intellectual father of the concept of those first health centers here in Boston at Columbia Point and Mount Bayou, Mississippi. If you read Jack's initial writings, the descriptions of the health centers, they were not only about primary care. They developed or were built around the concept that actually Jack observed when he was a medical student traveling to South Africa, and he witnessed this, of community-oriented primary care, where those health centers were also mini public health departments. They combined a personal health services piece with population caring, okay? That was the original model. Even when we thought about health centers in this country, I won't go through the whole history as to why the population part got off track in many ways. Not that health centers don't do it, they try, but that's not what they've fundamentally been about. But you can imagine when you live in an American health system that developed, around financial incentives, fee for service, about the individual in front of you, and even health centers are paid that way for the most part, to move from beyond individual care to covered lives care, which I'll talk about briefly, and then population care is not easy. Do I want? What are you asking me? I'm sorry. I figure I'd go without the slides. Okay. I only put a couple of them up, so I figured I'd go with that. And the main slide I was going to show you was there is individual caring concepts, there's covered lives concepts, and there's population health concepts. Now, I'm going to put my physician hat on for a moment. When you train in medical school, whether it was me historically 25, 30 years ago, or even the doctors today, I'll say sadly this way, for the most part, it's all about the individual lives caring. It doesn't mean that we aren't teaching students about covered lives caring, which is, if you have an enrolled population, how do you think about the resources in managing their health? And enrolled is important here. So for example, Kaiser Permanente, which for many years has been sort of the staff model HMO and even pays doctors' salaries and the like. If you look at, until about 10, 15 years ago, Kaiser did really very little population care. Okay, they focused on what individuals coming in for services and did a lot about thinking about the enrolled lives. But moving them beyond that to the broader populations was not something that was historically in their DNA, for example. And so there are important skills as you move from, and we're trying to teach them in medical school, as you move from individual caring to covered lives caring. And some of those are quantitative skills of epidemiologic concepts, etc. It's about, at some level, health communication skills, how you do the right messaging. I won't go through them all. But all of a sudden, when you're not just worried only about the patient in front of you, but looking at a group of people, there's a new skill set. It isn't only about what doctors do. It's a team effort of other clinicians and administrators. But to get you beyond the four walls, I was worked in hospitals, and I was part of a group of folks that the community benefits concept, which I'll mention briefly. I was part of a group at NYU almost a little over 20 years ago that tried to take that notion, which was built really about why we grant tax exemption to hospitals. It's because they promote benefits to communities, and nobody really ever understood what that meant. It was built around free care concepts. Instead, we tried to breathe a public health notion into it, having a defined community, improving its health status, dealing with disparities, and cost issues. That the community benefits movement has tried to move hospitals a little bit this direction too, but it's a slow process. Because part of it is it's easiest and hardest to imagine how do you deal with a group of people out there who don't interact with you, whether you're an individual doctor or a hospital, and somehow feel responsibility for them when the payment source of what makes you do your business day to day is really disconnected to that. So there clearly needs to be the financial alignment piece. For physicians and others, there's also a skills piece, but it's also a perspective piece too. And the notion of let me bring us to the present day. The challenge of the present day, if you talk to a provider right now, is that it's sort of like, they're in a 7-game series, and they're down 3-2, and the score's 12-12, and it's extra innings, and they've used all the relief pitchers, and now they got to pull the starter out, who's supposed to start tomorrow, the 7th game, if they get there, right? So the point is that they're struggling just to make it under traditional fee-for-service. So we got to put that starter in there just to win today's game to stay alive for tomorrow. But then we also sort of got to prepare for tomorrow too, because even if we win today, we haven't won yet. So the point is that especially smaller hospitals, which don't have the amount of resources, they're trying to stay alive based on that fee-for-service umbrella, when you're hearing the language is and put up of capitation, managing within fixed resources, health status, getting the most out of the bank for a fixed amount of resources, and then having the incentives and the ability to navigate your own institution and the docs that you relate to all aligned doing that, not so easy, because it doesn't just switch on a dime. So the biggest challenge for the system right now is sort of maximizing their rate of return as they think about it, in some cases just to make it for some of the more challenged institutions in the present day, and then preparing themselves for the future. And so I want you to think about how you connect with people that want to do that. But let me turn to a moment of hope, I guess, or way of thinking about it is that as we move from fee-for-service, and again, the bank today is primarily on covered lives and care. I think and it's covered lives carrying, which we've been doing in Massachusetts under some managed care banner for a while, but it really distorted the fact that the payment system was really a fee-for-service system associated with it. We're trying to move that payment system more to a global budget concept, which then says for a group of people that you're responsible for, at a broader level, you got a fixed amount of resources. How do you do the best for them? And even there's problems because I won't detail other than to say that there might be a global payment coming in from someone. It took me minutes, I should be there. But underneath that, how you pay the individual provider still might be fee-for-service. So even though you got somebody managing a budget of dollars, in theory that budget of dollars tied to a group of people to sort of keep them healthier so that you use less total resources, you're not in complete control because you're still paying the doctor who that patient encounters fee-for-service ultimately, and their incentive is still to do a lot of care. And so you've taken you've made some strides in that the ultimate budget might well be fixed there, but you haven't necessarily at the individual patient level saying, is my doctor's incentive who's in front of me aligned with doing absolutely, the best thing for me that's, always in my interest, and there's no aspect of financial interest to that clinician. We're still not there yet, folks. Even although we use the terms like global payment contracts. All right. But ultimately, and this is key, I think, is we do move the system, especially if we can move more of the providers, individual providers, to where they are paid, and their own individual incentives are no longer volume-based, but more of them, let's say, are salaried or capitated, and they derive a larger portion of their income from sort of doing the right thing in an aligned sort of way. I think that's where we're all aiming towards, and as they try to do that, and if you think about managing within fixed resources to doing that, the medical care system will quickly learn they can't do that on their own. They need those community resources. If they're going to be managing diabetics more effectively, they've got to work with those who are going to help support those people to be able to exercise or eat healthier, and that goes well beyond the medical care system. I'll leave you with this last fact, I think, and then I want to hear from Tom. The average diabetic, they say, did a study on this, about 1,200 hours of their waking life each year, sort of either actively engaged in or thinking about a decision, usually around activity or diet or medication as a result of their diabetes. 1,200 hours of their life. Only 2 of those are they in front of a provider, okay, on average, if they're not too sick. 2 out of 1,200. So the question is, who's supporting that diabetic those other 1,198 hours to do the right thing? Family member, person sitting next to them in church, standing next to them at the soccer field, you at the health club, the local school that's both trying to educate the kid as well as maybe pull the parent in. So if you ultimately have a system where the resources say, here's how much the total providers are going to get, lock, stock, and barrel, to care for that diabetic for the year, and somebody's got to figure out how to manage those expenses, what they're going to find is they're going to need to invest those monies in the kinds of organizations and people that are interacting with that person well beyond the 2 hours in front of the clinician. So those other 1,198 hours probably matter the most. And that's where we all come in a population health set. So I'll stop there.
So next we have Dr. Tom Land, who's the Director of Health Information Policy and Informatics, a new office at the Department of Public Health. Dr. Land has been really renowned nationally for his early research centered around the impact of tobacco use and tobacco policies on health outcomes. This work has included documenting reductions in heart attack deaths related to our Massachusetts smoke-free workplace law. Dr. Land leads a team that has developed a comprehensive evaluation of clinical and community initiatives that are person-focused. His work includes managing the development of a generalized bi-directional e-referral system that links clinical and community settings, as well as the development of an extensive surveillance system to track and link telephone survey and field data through geocodes. Dr. Land.
Thank you, Commissioner. Thank you, Ann Paul. Can you hear me? Okay. It seems like for the past 30 years, every project I've ever worked on has felt like a patchwork of all sorts of stuff that gets put in front of you. Some of them have worked out well, some of them have looked like patchworks at the end, and you can blame the seamstress for that. But my presentation will be an attempt to show you some of the patches and an attempt to try to stitch them together in a description of what we're trying to do with the Prevention and Wellness Trust. So I'm going to cover the bi-directional electronic referral system, some health information systems that we're working on in conjunction with the Metropolitan Area Planning Council, as well as the Prevention and Wellness Trust, and I'll give a shout out to the AAA, but also to some other projects that are happening. So the bi-directional e-referral system, it's actually an open source system. It's open source, vendor neutral, bi-directional e-referral to promote community clinical linkages, which sounds really impressive, but I think the most impressive part of it is that's probably the only sentence you'll hear in your entire life that has 5 hyphens in it. So this is part of the CMS State Innovation Model Award that Ann manages, and it's a relatively small part of it, roughly 10% of the total budget. And what we're trying to do is build a system that promotes the conversation between clinical systems and all of the community-based organizations that are out there. So we chose those that we thought we would have the most impact with. And again, this is about the AAA because we're trying to improve patient experience by connecting them to community resources, to improve health outcomes, and to save money. So the first thing we had to do is we actually had to define what a community referral was. So a lot of people would come up with somewhat different ideas. So a bi-directional referral to us is something that actually was the complete transit all the way from the provider's office through the community services that are provided to the individual, with a feedback report telling that provider what happened on the outside, and then that information gets deposited back into the patient's medical record for 2 purposes. One is that the provider needs to know what happened, and that it allows us to evaluate the effectiveness of these services in terms of the clinical outcomes of the patient. This is the schematic that we use to describe what that bi-directional referral system means. And on the left-hand side is the vendor-neutral part of it. So essentially what we're saying is we're building something that it doesn't matter what type of electronic health record system the provider is using, that whether it's NextGen or Epic or eClinicalWorks or Allscripts, that this system will allow the conversation between the provider and the community-based organization, regardless of what's on the left-hand side of that equation. And on the right-hand side of the equation are all the community-based organizations. So that's the linkage part of it. That's the second hyphen. But what happens in the middle is this translator system, which we're trying to say is the way in which you can get as many people in the conversation as possible. It's a universal translator model. Nothing's ever completely universal, but we believe that by permitting as many types of conversations as possible that are defined by the provider and the community-based organization. We don't define them for them, that we can increase the likelihood that people talk to each other. So these are the groups that we're working with, the Smokers Quit Line, the Massachusetts Tobacco Cessation Helpline, the YMCA of Massachusetts, Visiting Nurses Associations, and Councils on Aging. And you've got a list of the different health outcomes that we are, or behaviors that we are trying to impact with this program. So, actually, I have to look ahead to see where I am. So again, this is the aspects of this that we really want to emphasize are that this is an open source software, that it has a node on the Mass Highway. So again, it's available to all providers. It's not just available to the set that we're working with in our State of Innovation Model Award. We have intensive TA for the CHCs that are working with us, but we're developing a toolkit for all of the different providers around the state that will allow them to ultimately connect to this through either the Mass Highway or directly through the Universal Translator. So this is a tool that we think that people can use, and what we'd like to do is the open source system should be available around June of next year, and we'll begin rolling out the toolkits after that so people can begin to utilize them. Health information is another part of what we try to promote at the Department of Public Health, and this is going to be an ultra-quick tour of what we've been working on with the Metropolitan Area Planning Council. We developed a website which looks rather hard to see, but this is called OurHealthyMass.org, and Our Healthy Mass is essentially public health information in a way that allows the public to use the information. It's not predefined by the Department of Public Health or some other entity. It's a very flexible system that it is, we provide some information like data stories about different communities, but what we're really trying to do is get people to actively use the information. So they can put any combination of information together with any other combination of information and look at that in terms of where their community or their region lies with respect to the rest of the state. So Our Healthy Mass is, again, something that is a public-facing website. It uses the Weave visualization platform. It's very graphic. It sometimes is intimidating to some people the first time they use it, but it's also designed for both beginners and advanced users. There are virtually limitless combinations of information that can be presented by the purveyors of this or by the users of it. And we're currently exploring, the Metropolitan Area Planning Council, in conjunction with the Department of Public Health, have applied through the Knight Ridder Foundation to develop this into an automated health impact assessment tool for people to use. So how does this all come together in the Prevention and Wellness Trust? The Prevention and Wellness Trust is a combination of trying to utilize the information and use that information to define a health system or a program that is rolled out in communities or regional areas that, again, achieves the AAA, but it improves patient experiences, it reduces health chronic outcomes for patients, and saves money. So, again, it's a $57 million fund over 4 years. We're into about the 4th or 5th month of this, so we've got roughly 3.5 years left. There's no requirement for spending money annually, so this is, again, flexibility that the Department of Public Health generally doesn't have when we work off of a fiscal year. At least 75% of the money has to go to grantees. No more than 10% will go to worksite wellness, and no more than 50% for administration by the Department of Public Health. So from an evaluator's point of view, the fact that the outcome measures are actually written into the law has really given a different perspective on this program than you often see. And these outcome measures are reducing the prevalence of preventable health conditions, which has been mentioned several times, reducing healthcare costs or the growth in healthcare costs. And we also need to look at the beneficiaries of any cost reductions or savings. So if there's a particular subgroup that benefits more than another, this is part of what we have to talk about in our final reports. There's a worksite wellness part of this, and we have to look at employee health, productivity, recidivism, and through our workplace wellness initiatives. And finally, all of this has to be done in 4 years. So this is again, all of these daunting elements, but those elements became the became the rubrics that we used in order to look at how we would plan something like this. So we started with a set of guiding principles. We said we wanted to use evidence-based interventions. We wanted to target areas with high incidence because, again, we thought if you target areas with high incidence, you're more likely to achieve your goals. We look at risk factors and diseases that lead to significant cost savings because not everything does. We promote strong linkages between clinical and community, and we look to maximize return on investment while we are also producing what we hope are sustainable changes in these communities. So we looked at a lot of data. We looked at things like inpatient hospitalization charges for diabetes. We actually looked at 13 different health conditions that had some evidence for showing improvements in either health conditions or costs. So this is a graph for diabetes. It's going up. That's the wrong way. This is a graph of how it looks like. We looked at regional differences within the states. So this is the prevalence of hypertension. Not every community has as high a rate of hypertension as other states do. We also looked at things like gateway communities. How do these different things align with each other? So our gateway communities have a higher prevalence of different health conditions than others. And we put all of this together into a plan where we looked at priority, optional, and other conditions. We chose the 4 priority conditions because they had the highest likelihood of showing healthcare cost savings and improvements in health over a 4-year period. We looked at the types of interventions that were available where there was evidence to demonstrate effectiveness for these, and the tobacco use, pediatric asthma, hypertension, and falls prevention among older adults were those that showed the highest likelihood, in our opinion. We've had a lot of, the Prevention Wellness Advisory Board reviewed this. This was something where we got a lot of input from a lot of public health departments, from within our own department, from universities in order to look at this and determine that these were the most likely candidates. The optional ones are ones that have less evidence to show short-term healthcare cost savings, but there's definitely evidence that they improve health and show healthcare cost savings. And finally, there are those that where there may be emerging evidence, and we wanted to have communities have an opportunity to propose ideas that would be evidence-informed as well as evidence-based. All of these can be done in conjunction with on vulnerable populations or to emphasize mental health or behavioral health issues across all of these conditions, and the applications are coming to us around November 1st at noon, and at that point we begin the review process. Another really key aspect of this is that we didn't want to create a bunch of mini silos in communities. What we wanted to do was we wanted to require communities to work in all 3 domains, clinical, community, and a clinical-community linkage. So every health condition for which an intervention is proposed in a community has to have something in the community, clinical, and the linkage area. So they can't just propose something that's clinical or something that's community. They have to propose all 3. So again, what we're trying to do here is applying all that knowledge. We've used the data that we have developed over the last decade in public health to look at the impact on the public for healthcare costs. And we're trying to align this with other Department of Public Health programs so that we have efficiencies like Community Transformation, Mass in Motion, and the CMS State Innovations Awards. And the applications, as I said, are due November 1st. There were half a dozen other things that I could have included in here, looking at the APCD, ways that the department can use meaningful use to promote public health outcomes. I just wanted to put this one up because it aligns very closely with the Affordable Care Act and the community health needs assessment requirements that are required for within the IRS regulations. And again, this is something where hospitals and communities can work together. It's a requirement. It's not something that again is done in a vacuum. This requires community involvement. So again, I think this promotes the conversation across community and clinical settings, so that we have the highest likelihood of having a change in the system, and in this case, the system being the conversations that take place in each of these communities. Thank you.
The e-referral system is so exciting. This is actually the first time that I've sort of heard it all explained. Could you describe in practical, can you all hear me? Yes. Can you describe in some practical terms how the community will access the system, and will there be a portal that people can use in terms of, so there's a referral made, person needs chronic disease self-management program and needs to have increased physical activity because they have hypertension, diabetes, and heart disease. So then that goes into this e-referral. And then is there some sort of system where you can deal with the heterogeneity of the population that you're looking at, so they get to a Y, they get to a council on aging, they get to wherever they need to be going, and then there's feedback on the other end about the appropriateness of the referral and feedback on what happens?
Sort of the short answer is yes. But when we were planning this, we looked at what the capabilities were of each of the organizations that we would be working with. So in order to demonstrate the effectiveness on the clinical side, we chose to work with community health centers because they had a very well-developed data system for us in order to permit the evaluation of the effectiveness of this. That wasn't certainly the only way that we could have chosen, but we knew we had a quick avenue to demonstrate the effectiveness. On the other side of it, this was developed so that it patterned an existing system that was commercially based that the Tobacco Control Program uses to refer people for tobacco cessation services to the state quit line. The Tobacco Cessation Program at the Department of Public Health has a database. They've got a system. John Snow Incorporated has great capability to send and receive messages. That's not true necessarily for YMCAs, Councils on Aging, VNAs. Some may have more capability than others. So our development is not only an open source for this universal translator in the middle, but it's also a portal for people for those organizations that don't have the electronic capability. It looks essentially like an email system. You get an email that comes in that says, there's a referral for you. You send an email, what looks like an email back through the universal translator to the provider, and that gets deposited into the, next June, gets deposited into the electronic medical record. But that's the plan, that all of this information gets tracked. So the evaluation, once again, is we can look at what the traffic looks like. So we can say, from a process point of view, if it takes 10 days to get a message back, then maybe there's some QI that you can do with the organization to say you're not getting back to those people who are referred as quickly as they need to, and work more quickly to respond to those requests. So the real short answer is that we try to build this so it's flexible, so that the provider can send a message, but then if the community resource doesn't have the capability, that's available to them as well.
Thank you. Over here?
Yeah, I'm a local...
Could you stand? Sure.
And Noreen Burke, I'm the Public Health Director for the City of Gloucester. And I just want to ask the panel, so I'm one of 351 of this fragmented public health system we have in Massachusetts. And as I sit here and, hearing all this affordable care stuff, so as local public health, so we're kind of a typical public health department doing sanitation and testing the water in the beaches to make sure people can swim safely in the summer, and protecting the food program and the restaurants, and I've done coalition work, and we're in these competitive silos chasing grants. But how does a local public health department and a local board of health, progressively minded people, sort of prepare for all this stuff that's happening in the world of healthcare? And we serve the 700 people from the 1960s who don't end up in the hospital. They come to us for the flu vaccine or the shingles vaccine, but I'm trying to grapple with where I take my health department over the next 3 to 5 years in relationship to all this. So that's my question.
Looking at, and through Jeff Wilkinson's leadership, is this idea of districts, and many other states have county health departments, which is an easier way of bringing people together. And I know that we don't have counties anymore in Massachusetts, but we're hopeful that over time, we do have, that's right, I'm from Barnstable County, we have a county, the only county, and in a county health department, but that people will start to realize that coming together will provide benefit to the community. And I think we have many examples where we're trying to help communities see that value around mass in motion, community transformation grants. So there's no reason why, and I think many municipalities have to be part of this prevention and wellness trust. And I would say find out if there's a prevention and wellness trust in your area and get actively involved in that, because we'll be looking at, did this community clinical linkage really bring the partners to the table, and it isn't just the big healthcare system seeing this as an opportunity to get more money and not really engage in the way that we think changes the system.
I have additional thought. You know, in the broadest sense, and I think it's true at a local level, you know, your charge is assessment, assurance, policy development in the classical sense. I think, though, that if you look at one of the weakest areas of the provider system historically, it's been around community engagement and knowing how to reach out to the various population overall and subpopulations in communities that in many ways need to engage in all sort, you know, in discussion, dialogue, maybe ultimately even how to dedicate resources at a community level. You guys might be the organizer. You might be the most logical organizers of that kind of dialogue discussion at a community level, more so than any other entity. I'm not saying it's going to be true in every 351 town and city in our state, but I think that's an important way, because, you know, the whether it's a hospital perspective or the different small provider groups perspective, or many of which, at least historically, unorganized, I'm not sure they know how to connect to broader population constituencies, but I think you as the local health department are heads above many other entities that potentially do that.
Yes, over here.
Yeah, I'm wondering, as we move towards this new service delivery model, and we've heard a little bit about the provider's role, the public health role, the community organization role. I'm wondering about the consumer, the patient, in terms of being able to direct their own care. I mean, what rights do they have? Is it top-down, this is what I'm presenting to you? Do they have some kind of...
Let me address Chapter 224, what it tries to do, and then maybe my colleagues will want to build on that. For better or for worse, and there's different debate about this, but one of the central aspects of Chapter 224 is this notion of greater transparency at the individual consumer level, okay? So since October 1 of this year, any of us that have an insurance card in our pocket, and I think it's true whether we're self-insured plan through our employer or we have traditional insurance, at least on the commercial side, that you should be able to contact your insurer via the web or the phone, and the web piece is still being developed, to get information about cost and quality information for some choices of care that you have tied to providers that you might want to consider. Let me say it a different way. That you ought to be able to find out, based on your insurance card, for a given diagnosis or condition, if you go to an individual doctor or you go to a hospital for inpatient, outpatient care, both what you're going to have to pay out of pocket for that service based on your own insurance plan, but also what the insurer is going to be sending as a check to that provider for the care. And you can compare, in some cases, one provider versus the other. That's part of the intention, is that you'd be able to do that. There also should be, in a very crude way, I say this, quality data in some instances that are available to you to help you make that decision. Over time, that data ought to improve. But the central theme here is that the law, and we are more advanced in this than any other state in the country, okay, as early as we are in development, to try to empower the individual patient to get that kind of cost and quality data. Now, whether people want to use it and know how, and will be able to get what they want to make a decision, and then use it in a comparative way to hopefully make a good decision for themselves, I think remains unclear. But that's at least one of the things that Chapter 224 is counting on.
Trying to ensure that people look at substance abuse and other health conditions where they try to weave this into the conversation throughout the activities that they plan. And although there's clearly an emphasis on secondary prevention with the Prevention and Wellness Trust, we're not trying to do this at the exclusion of primary prevention. What we're trying to do is balance this so that we can achieve the goals. And so I think this is not something that is entirely specific to substance abuse, but it is a way in which we are trying to ensure that both parts of the conversation take place, that we're looking at secondary and primary, and trying to ensure that the providers and the communities look at the whole health of the patient and not something that is as narrow, just a single health condition.
I just wanted to put in a plug for something that I'm personally very excited about, which is part of the State Innovation Model Grant. We are enhancing some of the support that we provide to pediatricians. We have a program called the Massachusetts Child Psychiatry Access Project, which supports pediatricians to take care of patients who have mental health conditions, and we are under the SIM grant expanding that to include substance abuse competency, both around screening and also around treatment, and that's a capacity that we think is very important. So I wanted to put in a plug for that piece as well.
At the Health Policy Commission level, one thing we're trying to do, we have set a pot of $120 million to give out to community hospitals that are trying to revitalize and be transformed for the world to come. And we decided that, and they're going to be applying for grants, that the whole behavioral health, both behavioral health integration with primary care as well as both behavioral health and substance abuse services are important areas for them to apply for grants for in terms of transforming what they try to do, including not only within the four walls of their organization, but some of the monies is going to be encouraged to how they connect with community providers around those topics. So we shall see what those grant applications look like.
So I want to say thank you once again to a great panel, and just remind you that I want to make sure we got our 5 triple aims in, that today we were here to really talk about improving the patient experience, improving population health outcomes, and reducing costs, and I think Massachusetts is well on its way to achieving those goals. Thank you.